So I think we can start now, yes?
Okay.
Now we are going to have our second session of today, and we have the China paper and the paper of India. For the first part of this session, Jean-Louis Denis was supposed to be, he's coming now. He'll be the chair. And in the second part of the section for the paper on China, it's David Hunter. There, yes?
Which one is first? I have to say, this is Jerry.
The first one is Jerry.
Okay, yeah, I have to leave at 3, but yes. Louis will present.
Yes, yeah. So we can start already this session on China. Jean-Louis is with you, and may I tell you that Nick is not coming, he's busy. I'm just going to read 2 questions that he has for the authors. And then we have Bijoya and Stephen who are going to comment. Yes? So with you, Jean-Louis, now.
Louis, are you?
You can start, Jean-Louis. Unmute your microphone.
Jean-Louis, it's not me.
Oh, no?
No, I presented previously.
Oh, chair.
No, just to chair.
Just to what?
To chair the section.
Oh, okay, sorry.
You can present the paper if you want to. I'll send it over.
No. I must say I'm overwhelmed these days. I did not check the agenda. But okay, yes, I chair the session. Please, you have 20 minutes and I have the paper on the screen. Thank you. Apologize for this.
Okay. I'll try and share my screen. Actually, Fabiana, can you do it? I'm not really sure how to do this.
Okay, I'll do it.
I'm a bit rubbish at this. Would you mind?
No, that's fine.
Thank you.
I just need to have it. I included the Dropbox. Let me just say my documents. Okay.
Well, while we're waiting for this to come up, I'll start sort of giving you a bit of background anyway, because the paper we've titled Building Policy Capacity for Managing Rapid, Complex Change in China's Health System. The paper is by 3 of us, me, Jerry, who's also on the call, and Xiao, who was going to be here, but I presume has been a bit held up. This draws on work that all 3 of us have done in different capacities at different points in time, really around change management processes in China and in relation to China's health system. Jerry has been at the IDS for a long time and working on these issues. Xiao is with the National Health Development Research Center in China, which is a policy-related research institute and think tank, which does work on a lot of things related to the way that China's health system functions. And their center does a lot on, for example, policy evaluations, evaluation of reforms at the local level in China.
It's on the screen now.
It's on the screen, great. This is sort of IDS and CNHDRC, but really it's around, we're sort of coming from this change management process to think about China. Could I have the next slide, please? Thank you. So this really is just to give a little bit on the sort of overall framing that we're coming with. Thinking about policy capacity as a lens on health system reform in China. And the reason why China and why China is interesting, we think, apart from the fact that this is, what we all spend a lot of time thinking about is that it's a country that has been undergoing extremely rapid fundamental transformation for what seems like forever now, as in at least since the late 1970s, early 80s, and the beginning of reforms in the country. So, that's why really we're talking about a change management process here, because how do you really kind of keep these reforms going? How do you keep the show on the road, as it were? And where does this then interface with the framework from Viao? I mean, how well does that framework allow us to describe or to analyze what we're seeing in China? And if it doesn't, then what do we need to think about adding on to that framework in order to kind of describe and analyze the sorts of things that we are seeing in China? I think the PowerPoint appears to have slipped, Fabiana. Could we have the slide 3, please? Thank you. So just very briefly to start really with what I think we took away from the Viao framework. One of the, so could we have the following slide?
Yeah.
Thank you.
Next.
Sorry, could we have the one below, please, Fabiana? This is my fault for not being able to, no, up one. This is my fault for not being able to use Zoom properly.
That's fine. Just say next. Next.
So,
Okay.
Up one.
Up
one. One before, Fabiana. Yeah, perfect. No, continue. Okay, right.
Slide
next, if we start
Slide
again.
3.
Next, please. Okay. Yeah, perfect. Thank you. So, I mean, what we're really taking away from this is that, this is actually intended to be a very practical framework to allow decision makers, analysts, researchers, and so forth to be able to analyze policy deficits and think about the capacities that are needed for effective policy design and implementation. So a very practical thing that has to be implementable and usable. There are kind of nods towards complexity in there in ways that they talk to some extent about the fact that you need combinations of skills and resources, but it doesn't appear to be explicitly there in this framework. And the framework doesn't really explicitly account for change or talk about this in a dynamic way, as far as we could see. Next, please, Fabiana. So, I mean, we came with some initial observations around this, thinking really from the point of view of things that we've observed in China, which is that in dealing with particular issues or particular problems, you actually really need very specific sets of capacities, and capacities are specific to problems. There's a limit to which you can really talk about generic capacities. The sort of point 2 then is that the kinds of rapid change that we see in places like China creates what we describe in the paper as both contemporaneous and dynamic changes. Contemporaneous being that high levels of complexity, imperfect information or absent information, complete lack of data possibly on what it is that you might want to address, unclear institutional arrangements, unclear boundaries, unclear who is doing what, how, and to whom. These are very challenging things to be working with in the here and now. But there's also a kind of dynamic set of challenges around developing stable institutional arrangements and thinking about how you allocate and distribute capacities across the system over time. So this really led us to kind of thinking about the question about how can policy systems rapidly and adaptively develop capacities when problems to change may change rapidly. And I mean, that's what we really see in the case of China, is very, very rapid change, need for changing capacities. So next slide, please, Fabiana. So a couple of background things. I mean, when thinking about this, we're really thinking about health systems as in sort of institutional sense of trying to think about systems that are attempts at building rules-based orders for providing services, for governing the interactions of many different agents. that getting to those kinds of systems, finding those arrangements requires dynamic processes of experimentation, adaptation, developing new rules of the game, as it were, as you go along. And also something that's very obvious from the China case, which we'll come back to possibly briefly a little bit later, is also that in most changes processes aren't very linear. There are periods of secular change in which you may see things that progress in a sort of gradual way, but frequently punctuated by shocks, which then change the rules or require a substantial readjustment. Next one, please, Fabiana. So the second bit of background really was then to say something about China, because it's a background to the case more than about the case itself. But as I've said, I mean, we can see this rapid and fundamental reform since the 1970s. And I think it's easy to underestimate quite how substantial, quite how fundamental that has been. I mean, the transition from a whole system based on effectively command economy institutions to one that's becoming much more sort of built around market economy institutions. That the whole of the government system has had to be dismantled and reconfigured in many ways in order to perform new tasks. And this is a huge institutional restructuring process. It's obvious that China is large, but it is so astonishingly large that, you know, when you're trying to manage, can we go up again one, Fabiana? We've slipped down a little bit. There's a lot of decentralized.
Back one, back one.
Back two now.
Perfect.
Yeah.
No.
Down one.
One more.
That should be right. Yes, perfect. Thank you. So, I mean, it's obvious to say that China's large, but the degree of decentralization or partial decentralization in the way that reforms are managed and the way that things, particularly in the social sector and in provision of healthcare, an awful lot of things are managed at very low levels of government with not necessarily very large levels of capacity, and limited levers effectively for controlling government behavior or the behavior of all these different sets of actors in these very kind of complex and rapidly changing systems. And there's a lot of potential for destabilizing errors. I mean, one of the things that this leads to is a very strong tradition of policy experimentation, innovation and learning that's pretty much embedded within the Chinese system. Saying that does coexist with obviously a very strong government when it wants to be strong, that has a major role in direction setting and managing these kind of processes of ongoing adaptation and adjustment. And something particular to this, the argument that we're going to sort of talk through around the health system, but also a long history of supporting research and building analytical capacity. I mean, we can see the development of the Chinese Academy of Sciences and Chinese Academy of Social Sciences and all these major research institutions from the 1950s and onwards. These are all sort of somewhat fundamental things around what we're looking at when we're looking at China, not necessarily particular to this case, but they're major background components. Next, please, Fabiana. So, I mean, when we were thinking about this in terms of China's health reforms, what we've done is to take a sort of three-period look at some challenges and how they've been dealt with, and look at these through the lens of the framework from Wetal. This is retrospective, and it's looking back to basically the sort of, I mean, it's looking back really to the early 90s. But the three periods really are adaptation of the health sector to transition to a market economy, increasing inclusion, and building rules-based institutional arrangements. And that will become clearer as I go through. But I mean, to preempt a bit what we'll come to in a moment, but what we see really is that we see substantial changes in the challenges across all these three periods and across all the three dimensions of policy capacity, and that has implications for where we're going to end up with the argument really. Next slide, please, Fabiana. Thank you. there's a lot too much text on this slide. I couldn't really find a way to do it other than this sort of way. What this is really trying to say, and there are 3 slides that do this, one for each of the different periods we're thinking about. This one is adaptation of the health sector to a transition to a market economy. So we're really talking about the early period of China's reforms until around 2000 or so. But I mean, really, the sort of the top line bit here really is around the background, because the health sector is not changing independently of its sort of surrounding economic and other institutions, social institutions. And there are a lot of challenges and forces that are coming out of this that are then prompting the changes that we see, including, in this case, at this sort of point in time, decollectivization of agriculture, rural government revenues plummeting, health services, facilities being starved in revenue, having to charge for services, leading to increasing out-of-pocket payments, inability to pay, and an awful lot of things that they're sort of very common challenges, but there's a lot of dynamics there around what really shaped the adaptation of the health service in that period of time. And what I'm trying to do here then is to say, okay, so in the analytical domain, in the operational domain, in the political domain, what are we seeing? And to sort of put it crudely, and there's much more of a narrative around this in the paper, but to say that in this sort of early period, there was a lot of priority on solving problems around health financing. A lot of attempts by Chinese government to bring in capacity for this from development partners, from the World Bank, from working with UNICEF and others, in order to build this kind of capacity domestically. Building of networks and institutions to be able to embed this capacity within the system, which then, you know, I mean, this is all going back to sort of the late 80s or early 90s, but then the development over that kind of period into the 90s of increasing analysis that was then showing some of these problems, which had been largely speaking invisible or unanalyzable, but then being able to flag these things because of this building analytical capacity. But at the same time, looking through a sort of operational capacity lens, the great pressure to build basic management health service systems for health facilities, given that very many of them in rural areas particularly are decrepit, under poor management, with poorly trained staff who are relics of the Cultural Revolution era and before, and so forth. So an awful lot of things then going through about really strengthening that kind of level of operational capacity. At the political, looking through a political lens, we're really seeing economic growth as the priority, much less priority on social services and health and so forth. Lots of ongoing debates between the Ministry of Health that obviously wants to support, you know, more cash for health, but the Ministry of Agriculture that doesn't, because it's an extra burden on farmers and so forth. So, I mean, overall, the picture of changing kinds of capacity needs, analytical, operational, and political, against the background of this major transition from command economy and kind of the previous system towards a more marketized economy. Next slide, please, Fabiana. Thank you. This is really in the early 2000s, and I mean, what we saw very clearly in the early 2000s was the central government pushing a very, very different line on the social contract between the state and its population, particularly the rural population. The push for major rural health reforms, including the rollout of a major health insurance scheme across the whole country, but doing this under conditions of very limited capacity, and counties across the whole of China, so 3,000 odd counties, roughly speaking, having to take on the management of a complex system, but very, very rapidly. This got rolled out within a period of about 6 to 7, 8 years across the whole of the country. Analytically, there was a push to then develop capacity that could look at how a rural health insurance scheme functioned. Initially, very much around how you ensure fund safety, how you do things like basic accounting, how you make sure that this is actually functioning reasonably well. This is reflected then in also kind of setting up of national centres for research on this, within national think tank. Huge explosion in the amount of research on these things over the 2000s. Operationally speaking, major attempts to then build out capacity at this kind of level within, particularly in counties across China, people who are actually having to run these schemes. It's a huge effort, given that you've got 3,000 odd counties, and all of these people need to be able to run these kind of schemes. Also, a lot of huge amount of policy coming out from centre and from provinces in order to guide counties in how they do this stuff. All of this underpinned basically by a massive political push to change the way that the state thought about health services. Next one, please. Thank you. So if that was, we've had a kind of move from towards a market-based sort of system, away from the planned economy system. We've had pushing a degree of inclusion through the early 2000s and a kind of a major reconfiguration of the kind of the state's promise in providing healthcare, and then through to really kind of 2009 to the present, with a process of trying to launch a very major package of changing reforms across many different areas, and really very much trying to build much stronger institutional arrangements for the governance and management of healthcare. At a political level, if I start with that on this one, a lot of this really starts with a 2009 very, very major health service reform package. But then subsequently in the 2010s, we've seen what's called the Healthy China 2030 plan, which is a very, very broad-based strategy around China health services, but also healthy environments, healthy urbanization, health industries, and so forth, coming from a very, very high level of government as a guiding reform vision of how this is going to work, and backed up by the establishment of capacity, political capacity within the State Council, being China's central government, to push for this and to oversee it. The analytical capacity at this point is now getting stronger and stronger and stronger. It is, importantly, it's diversifying from being, when we were seeing, kind of going back, looking at financing and health economics, and now becoming much broader, with people looking at all sorts of different questions around how you build systems, how you institutionalize capacity, how you govern these kinds of systems, and operationally, much, a changing set of management tasks as the country tries to integrate, for example, rural and urban health insurance schemes to change the way that hospitals are managed, and that they respond to incentives from health insurance, state-backed health insurance schemes and so forth. So, I mean, if we look across these three periods, the periodization is slightly, heuristic, but there are very, very clear differences in the challenges and the evolution of the challenges, and very clear differences also particularly in the analytical and political streams here, so what has been necessary and what's been going on across these different periods. This is condensing a very, very long, complicated story into a few slides, and the paper hopefully sets it out in a bit more of a comprehensible way. But next slide, please, Fabiana. But having said this, I mean, what does this really mean? And I'm sorry to try and run through a complicated story in a couple of slides, but the challenges that we've seen have been, they've changed dramatically over time. They've changed not just because of the internal dynamics of the health system, but because of the changes in the surrounding political economy, and how that's then influenced how this health system is functioning, the changes have been enormous given the speed of China's development in this period. But what this has meant is that the capacities that are needed have changed. So, I mean, if we, the way that I've tried to map it here in the slides is that we can see across these three different periods if we look at analytical or operational or political capacities, all of these have changed across these periods, and they've got more complex. The actual capacities required in different periods of time are actually very specific. They're not sort of generic capacities. But what we've also seen, apart from the changing need and the increasing degree of complexity, is that the capacities have actually been specifically and dynamically adjusted over time as these challenges have come up and needed to be faced. And that's not to say that this has all been managed with some sort of blueprint from the start, and it was all very obvious and could be therefore put in place in a sort of in a very clear and logical way. If we dig through the ways in which these happen, which we do a bit more in the paper, there's a combination of things really here about reactive problem solving, some degree of anticipation of things, and then ongoing short-term adjustment of how different kinds of capacities are needed and are operationalized and put in place. And I think one of the things that also comes out pretty clearly over time is that we are not just are we seeing the increasing complexity of the different kinds of capacities needed and the ability to adjust those capacities, but we're also seeing the increasing kind of meta level capacity, which is that capacity to reflect on the way that the system functions and to adjust that system effectively in a short period of time. And one of the things that we explore in the paper more is around the increasing importance of think tanks and high-level research capacity, and also very specifically framing a lot of the way that China manages its reforms in terms of
maybe
policy learning.
1 minute and a half.
Okay, it's fine. I've got one slide to go. Thank you. Next slide, please. So, having said all that, I mean, what does any of this mean, and why is it not just really, in our view, just a China story? I mean, to come back to where we started, that we viewed the Oil et al. Framework as a very practical framework to support how you do decision making and how you think about the capacities that are needed. We've looked at a case of a country that's faced rapid, complex, destabilizing changes for 40 years and has somehow managed to basically keep going. Our argument in the paper is that actually it's not just China that faces this. It's not just a lot of developing countries that face this. These are problems that we all face and are going to increasingly face with destabilizing climate change and another number of other factors. We therefore think that based on this, that the kind of development distribution of policy capacity has to be a very dynamic process. And that's what we see in China, this ongoing system level learning and distribution and redistribution of capacities. And that this meta level capacity to adjust is actually extremely important. We see that in the Chinese case. However, one of the things and one of the limitations clearly in China and everywhere else, pretty much as far as my guess, is that there's a need for better ability to anticipate capacities, to be able to distribute them, to be able to put them in place in advance of their need, rather than short-term and reactive adjustment. And we see a balance of these things in China, but that's a sort of parting thought on how we all need to get better at doing these things. So really the case is that we can see certain things from China. We can see that other countries face rapid, complex changes. We believe there are some things to take away from here from the Chinese case about how to develop and deploy different types of policy capacity in relation to complex and rapidly changing situations. And we think that's something that's worth looking at in China in international sort of perspective to see that. So I will stop here, and very happy to hear thoughts and comments and questions. Thank you.
Okay, thank you. Very, very interesting paper that follow well our initial discussion this morning on the dynamic aspect of policy capacity. So we have 3 discussants. If I got the order right, we have Stephen, Bijoya, and Fabiana. That's the instruction I receive. So, Stephen.
Thanks very much, Jean-Louis. Thank you, Lewis and Jerry. Yeah, interesting paper, and it kind of touched on some things I know that we were discussing, Jerry, in the PhD Viva we're on. I mean, I think it's a good use of the framework to explore the kind of changing dynamics. I think from my point of view, and I noted, actually, I've just looked at Nick Turnbull's made some comments as well, that I'm quite interested in what Jean-Louis just said about the dynamic change issues. So it explains what the framework, I think, is probably used descriptively to show what has happened. And my question was, well, why? What were the factors which kind of contributed to policy change, and how does that intersect with the whole issue of capacity? I was thinking of Caroline Toohey's kind of way that intersects with kind of policy change, which then provides opportunities for particular capacities, and particularly political capacity, to change things and explain, well, not explain, but to look at that intersection between the dynamicism of policy change and the way that then it gets distributed around the capacities to actually do things in the system. I think my other key point goes back to something I was talking about this morning in relation to the paper this morning around multi-level governance. I mean, Nick raises a point which I thought was quite interesting about authoritarian states, and it kind of took me right back to some of my early public policy kind of academic training and things around this idea that in an authoritarian state, you clearly are able to prescribe what goes on.
Share Nick's comments, it's fine.
Yeah, sorry. Yeah, prescribe what happens across the system, but clearly it's a little bit more difficult and complex than that. So I was just thinking about in the Chinese system, you know, what things allow different bits of the subsystems within China to do things. You know, is it always prescribed, or is it that by changing the system, that the different capacities get times when they can be more powerful than in other places? So there is that, seems to me that it's an interdynamic system across the levels as well as anything else. And I think those two things probably could be discussed more and more an analytical way within this. And, you know, it's always because and I do like all the original text. So thinking about Simon's bounded rationality, none of the bits can know everything. So therefore, there will always be an interplay between the bits. And I thought that could have been brought up more, which would give a sense of why some of the dynamicism of the policy change itself, and drawing on maybe just some of the other policy theories. You know, punctuated equilibrium came in mind when I was looking at one of the dynamic changes. You know, or it may be that it is more about, I don't know, I mean, multiple streams, I think gets overstated most of the time, but, you know, just kind of thinking about that intersection to explain change. And I think that would add to the paper quite substantially. And I'll stop there.
Okay, Louis, do you prefer to intervene briefly between discussing? You have 3. Or you wait in the end?
I think actually, if I've got 3, I might go one by one, if that's all right.
Yes, briefly.
Yeah. No, I think those are both very good points. I buy the point about how you think about. Actually, I think actually the second point is particularly interesting here because of this. Question about multiple subsystems within one system and how those subsystems then interact, and how you think about the causes and the management of change in that kind of context. And I think what I can say is, I mean, there's a lot to say on this. I think how to then operationalize that across a kind of 3-period discussion of change in health system. Yeah, I mean, I think there are some interesting things to say there, and I think that's actually a very good suggestion to think about how to link this with some more sort of policy theories that will help bring those two things together. I haven't got a kind of clear answer for you on that one, but thank you. Yes, I think that's a very helpful suggestion.
I kind of wonder whether it's something that Fabiana and that we might think about across the papers, because there's often very little, focused on. And I think, Tim's set us off on a direction of thinking about local, but this idea of the different levels within policy systems, I think might be quite an interesting perspective. Sorry, I've shut up. I
mean, in a way, kind of Chinese studies has been struggling with this issue for now kind of 40-something years, of how you think about these complex nested systems and the different rules that apply to different subsystems and how those work across subsystems. I don't think we're going to solve this one, but to bring that in alongside this, to think about policy capacity and these two kind of things in the same kind of space might be interesting, I think. Thank you.
Thank you. I have to be brutal, so Bijoya, please, your comments.
Thank you for this brilliant paper. Well, as I was reading it, I found some similarities in our context, Indian context. I was thinking particularly the area where you are talking about increasing inclusion, where the health insurance system comes up. And I believe in Chinese context, it's not only the state sponsored, but as you are suggesting that the market players also come in. So in that context, I was trying to understand how do you take the non-state actors in understanding the policy capacity? Because there's a very interesting thing you say that, during this time, there's also increase in health sector expenditure, which doesn't happen in our context. So, yeah. Thank you.
Okay, thank you. I think, I mean, it's not really explored in great detail here, but we kind of nod towards the sort of complexity and the plurality of this system. It's not something that we go into in this analysis, but and this is, there are a number of reasons for that, I guess. I mean, one is that we have seen increasing use of private insurance in China. But the other, the dominant story here, which is what we're sort of really trying to capture, is that the challenge of how that, as state funding, government funding came in and increased, then what happened there, because in many ways, the starting point for an awful lot of this is the sudden disappearance of government funding in the 70s, 80s, which then left people with these problems of out-of-pocket payments and unaffordable healthcare. So while there has been increase in use of commercial insurance and multiple forms of commercial insurance alongside government schemes and so forth, but this was really trying to talk about it in around that kind of dominant government-led narrative. I mean, one of the questions though here is about how those different sets of agents as in sort of within a system all function together, and then you get really, I think, into, and it's, if you look at local level studies of this, what we can say is that this functions differently in different places, which is inevitable with a place the size of China and the different levels of development and so forth that there are. So I totally buy that there are a lot of things to dig into there. I think it's rather challenging in trying to do quite a lot of that in something that's looking at this sort of level of this level of abstraction. I think it could be something to look at in terms of individual case studies if we had a chance to do that. Thank you.
Thank you, Fabiana.
I'll just present two of the questions that Nick has sent, and then I will forward to the authors the whole comments, yeah, that Nick has made. One is that, given that this paper deals with policy capacity change over time, do the authors want to consider more systematic application of the framework explaining policy change? Another one, the authors claim that there are lessons from other countries, but would the political context not mitigate against such comparisons?
Thank you, Louis.
No,
Yeah.
no,
Easy to
I'll
answer.
send by email, yeah.
That's it. I mean, I think the first question is the one that we've touched on around how to think about policy change and how then that links with the capacity issues, and I take that on board. I think the second question is a very difficult one because, you know, to what extent do we think the Chinese political institutional system is unique or has unique capacities? And I mean, one of the things that I, and also Jerry and others have been doing Jerry and I worked together on the evaluation of a DFID program around China's global health engagement. I've been doing a lot of work with WHO on this. I mean, one of the questions that we really run into is, how do you do cross-country learning when you have a country that has such distinctive systems? And I mean, one of the sort of the emerging answers is around I mean, what I think we're looking at here is a set of meta institutions rather than a kind of meta level look at how you think about change. And I don't know that any of what we're seeing here is distinctive specifically to China's political system. There are bits where, for example, the institution of of targets that then help determine the way that local level governments implemented a health insurance system. Certainly, those are pretty hard to implement across a system of this scale without the kind of implementation power of the Chinese Communist Party and the Chinese state. But I mean, there are some sort of heuristics here which are not necessarily, we think, system specific, but are more around how you think about adaptation and learning and how you try and embed those systems. And I think also that those are not necessarily just properties of the Chinese system, in the sense that the Chinese system has not always displayed those properties or not necessarily always displayed them in those ways, and that therefore these are not just, I mean, there are a set of highly complicated questions here about the replicability or non-replicability of these kinds of processes that we're seeing. I don't think we have a fundamental answer yet to that, but there's a lot to be explored there, certainly.
Okay, thank you. Any burning comments or questions from the group?
I guess I would like to comment on the last thing. Because of course one could say the same thing, is the political structure of New Zealand make the lessons they've learned irrelevant to most other countries? So that problem we all have. It's just that there's been a dominant way of looking at adaptation and health policy, which is in a certain fairly small group of countries who have been stabilizing themselves really since the post-war period, although now may be facing more instability. So I think that's a high-level question for the introduction, how much these different experiences mean to each other. But I think it would be too big a compliment to the Chinese political system to say that they are uniquely able to cope with major shocks and changes and stabilize institutions.
Thank you. Any other comments, question?
No, just I've got one, Jean-Louis.
Yes, please.
It's just picking up on what Jerry's just said and on Nick's second point and on something Stephen Peckham said, which is the issue of how far Chinese exceptionalism is a concern, because many of the other countries we're dealing with do have similarities in a way that's not the case in the party state system in China. So I think if that issue is dealt with at the outset of the paper, it would put it in context, which I think is really important. It gets mentioned on page 13, but it's somewhat buried in what are called limitations of the paper. And I would have thought that element should be foregrounded in terms of what does such a system as China presents us with permit, by way of being able to do some things other countries may find difficult to do because they aren't as authoritarian in their political structure. And equally, does having a system like the Chinese system act as a barrier or impediment to doing things other countries can do more readily? So I think that would strengthen the ability to read across countries and learn across countries. Whereas I felt that dimension, the Chinese exceptionalism dimension, if I can call it that, was somewhat underplayed in the paper. But if that's going to be dealt with in introduction, as Jerry says, then I think that would deal with that problem. Thank you.
Okay. I think last question, Susan has a question. I don't know if it's just in the chat or a real one.
No, thank you. I don't see a way to lift up my hand, so I thought I would write it. But thank you. It's a fascinating paper, and I'm really interested, Louis, in what you looked at in order to define the three periods.
The three periods were not defined by us. We took that periodization from a study that was done looking at. It was done by it was another study that took that kind of periodization. It wasn't the rationale for that is really trying to. Actually, the rationale for that is largely. It kind of largely fits with the political strand of the kind of capacity that happens to come through in the capacity stuff here, in the sense that many of the guiding, basically the guiding thinking around that sort of first period, there's an awful lot of similarity, which then cascades down into the different kinds of capacities that we see and how they're operationalized. But conversely, there was a big major leadership change in direction around inclusion, around the kind of social compact in the early 2000s, which then set the paradigm, which we're kind of still living with. However, that was then inflected in around 2009 by, again, a major leadership change around bringing out a major, I mean, an enormous health system reform strategy and deciding to really pump money into the health system. So the periodization kind of comes from that. The periodization is largely political, basically, but it's then reflected. And it's funny that the extent to which actually it then does reflect in those different kinds of capacities, because once you start thinking in kind of analytical, kind of operational and political terms, you find that it does all kind of settle out in those ways. But that wasn't our periodization, but that's the rationale behind that periodization.
Okay, thank you. It's very interesting paper and conversation around institution change, enabling, disabling process and political context. We stop there, but more we discuss it, more it's interesting. I stop.
Okay. Thank you all. Now we have the next paper on India. David Hunter will chair the section, and then we have comments from Lewis and Fabiana. David,
okay. Thank you, Fabiana. Yeah, well, I'm very conscious we're up against the clock now. It's 10 to,
yes.
So we need to keep this fairly pacey in terms of the next session, which is our last one today. So, Bijoya, over to you in terms of presenting the case from India.
Thank you. Fabiana, I think you'll have to share the slides because not working for me.
Okay, I will do.
Can you speak closer to the microphone?
Yeah.
Just speak closer to your microphone, please.
Yeah. Can you hear me now?
Oh,
Better.
Yeah. Fabiana, can you share the?
Yes, I'm opening it.
Yeah. Okay.
Yeah.
Thank you.
Yes. No problem.
The title of my paper, as it goes, is Policy Capacity System Strengthening: The Case of Community Health Workers in India. It's a very early draft, and my area of work is on public health, but I've not been much into public policy. So yeah, can you move into the next slide? In India, actually this paper is emerging from another paper where we looked at the community health workers, their working conditions, and what is their present status. As we see in the early phase of 2000, in India, there's almost a new rural health policy emerges with the National Rural Health Mission coming up. And it came up with the revival of the Community Health Workers Program in India, and it was in a way a second time revival. And it actually aimed at the kind of enabling the healthcare system to effectively handle the increased allocations, promoting policies, and strengthening the public health management and service delivery in the country. And we see that over the years, the National Community Health Worker Program has gone through major reforms. And now, after almost 15 years, it has become a full-fledged subsystem of the primary healthcare and the district healthcare system. And the community health workers we are talking about here are primarily a cadre of non-professional frontline health workers from the marginalized communities who establish a link between the community and the formal healthcare system. And besides that, under the National Rural Health Mission at the very local level, two other institutions emerged. One was the Village Health and Sanitation Committee and the local Rogi Kalyan Samiti, which was for the hospital management. Fabiana, next slide. Next slide. Yeah. So we see that in India, the community health program, workers program has gone through major transformations, beginning with in 1977 and 2005. We see there's a distinct shift happening, and it became an all-women cadre. Next slide. Yeah, and we see the slide above this. Fabiana, the slide above this. Yeah, no. The fourth slide. Yeah. Okay.
The other
one?
The next?
Yeah, the fourth. Yeah, the next one. Yeah, the next one.
That's it.
Yeah.
That's the fourth.
Yeah, and we see the working of the community health work program at the state and the local level. And in 2005, when it started, the focus was only the rural health services. It is almost 10 years down the line when the National Urban Health Mission also formed, and community health work program was extended to the urban areas as well. And we see the field staff of the organization in three kinds of employment terms, which is permanent, contractual, and the volunteers. And it is implemented through the group of community health workers and public health team. The next slide. The next slide. Yeah. It is in this within this larger rural health policy transformation. I'm trying to understand how has policy capacity worked, and so we take a look at the Wu's and his colleagues definition and understanding, which is of the three skills: analytical, operational, or managerial, and the political, along the three levels, which is the individual, organizational, and the systemic. The next slide, Fabiana. Yeah, and as many other, as we have seen in the earlier slides, the other community health work programs which have come and gone. This is something which is staying here, and there is an effort to continuously uh, improve the community healthcare program here, and so, and this has also faced over the period of time various challenges, and we see how the policy capacity has been addressed at the individual level and at the organizational level. Now, one of the starting points of the community healthcare program in 2005 was also a series of studies which indicated that in LMIC countries, community health workers provided healthcare interventions, and they have had positive impact on some of the health programs like MCH and family planning. Now, during the early stages of reforms post 2005, the all women volunteer based cadre was one of the initial objectives to provide the MDGs and also meet the shortage of skilled workforce at the primary health care. And if you go back to the some of the papers during this time, and where it looks at the origins, it the the model also was derived from of the uh, community health work models which were operating in the NGO sector in India. And one of the famous is the Jamkhed model, which was in Maharashtra, which is one of the states here. And then, as we see in the last 15 years, various cohorts of ASHA workers has emerged. And we see that the program has been, whenever the program is discussed, it is discussed across the using the lens of which are need high focus states, non-high focus states, and the northeastern states. We have 35 states which have been categorized under these three broad categories. And as we see, they have created cohorts, and they have also at the same time created broader public health teams with other women health workers who are working as multi-purpose workers, and they're all women. And what we see that in case of women ashas, that they have definitely gained a quite good knowledge, technical skills, and opportunities. And at the same time, stepping out of home and working through the communities has given them social recognition and identity. Fabiana, the next slide. Thanks. Now, when we look at the working conditions, their work at the primary healthcare services has led to much greater mobility and interaction with the community. And we see that as volunteers, they are almost giving 6 to 7 hours per day, and which in the COVID-19 phase has extended beyond 10 to 12 hours. And ashas are given a wide range of activities, and their payment, however, their payments do not reflect any of that. And they're being volunteers, they do not have any minimum wage. Their entire work is based on the number of tasks they do. And and given the career mobility within the program is very little, and they're not recognized as workers, and they do not have any rights. As a result, many of the workplace violent cases which happens, uh, they cannot take it up with the health system. And this has created a lot of tension and frustrations. And certification as a form of recognition is in the planning process, but it's uh, uh, yet to come through. However, in the last 2 years, the government has extended the access to social security schemes and has marginally increased their minimum monthly incentive. And there has been a very common problem, which is of they're not getting the incentives on time, and there have been huge irregularities. However, with the online banking system which has come up, this has been partially arrested. And however, it also varies from states to states. The better developed states have better online banking system. And uh, and at the same time, and over the years, as being volunteers, they cannot form unions, but they have joined unions and they have formed associations, and they have periodically voiced their resistance against the precarious working conditions. Yeah, Fabiana, the next slide. Yeah. With the National Rural Health System Health Mission coming up, which is now termed as also the National Health Mission, they have clubbed the rural and the urban health mission together. We see that there have been um, centers which have emerged at the national and the state level. They have been termed as the National Health Resource Center and the State Health Resource Centers, and they have over the period developed literature around the working conditions, rules and regulations, and the government orders for community health workers. And they have also periodically evaluated these programs along with bringing up the review mission reports. Now they have, with these centers emerging at the state and the national health level, we see that there has been better data emerging on the issues around community health workers over the period of time. So one interesting thing is been the data around deployment of community health workers, and which has been the deployment has been shaped by the regional and the rural urban distributional needs, shortages and attrition level. The attrition level has been not very much absent in the literature around community health workers in India. It is in the last 5 years, attrition is being discussed. Uh, However, we continuously find that at the bureaucratic and the policymakers, they're consistent in continuing to make inconsistently they continue to support their voluntary status, and various reports, internal reports, and some of them are now with national resource centers and the state resource centers are digitally available also. So these reports uh, have have sustained the fact that and emphasized that their voluntary nature, assuming that it does not interfere with their other sources of livelihood. And yeah, the next slide. Yeah, and there has been a lot of emphasis over the period of time on task shifting with community. At the very beginning, it was the MDGs, but over the period of time, there has been a focus on NCDs, and it is in that context the preventive medical tasks. There have been a lot of dialogue in terms of shifting some of the medicals and training them and then shifting the medical skills to the community health workers. And we see there are various kinds of trainings which are coming. The induction and the refresher training is quite common, and they operate through modules, and every year they have a module, but the pace of training differs across the states and across the high focus, non-focus, and the northeast states. And we find that mentors have been recently appointed through the local cluster meetings. These meetings happen at the level below the district. In our administrative unit, it is called as the block level. And however, these mentor positions are not official postings. So these happen in an ad hoc manner, and these ad hocism we also see a lot has happened during COVID-19 with the ASHA workers in terms of allocation of their work. And recently there has been performance monitoring based indicators have been implemented for evaluating the ASHA performance, and at the same time for the district performance, it is also being used on a regular basis. However, there are variations in understanding and interpretation of these indicators, which is noted across the block and the districts. However, the feedback system is poor.
Joy, you've got 2 minutes. You've got 2 minutes.
Yes. Fabiana, the next slide. The next slide, Fabiana. Yeah, in the last 2 slides, I'm basically trying to focus on what is the nature of relationship with at the local level with the fellow public health workers and the local governance bodies and the healthcare centers. We see that the relationship with the public health functionaries has partly been streamlined. However, there are multiple cases where community health workers who are voluntary community health workers are forced to under corruptive practices by the mentors. Second is that they are not being involved in the district level and the block level planning. And here a lot of the social hierarchies, which are deeply embedded in our structural, comes into play. And large number of the community health workers are from the marginalized community. And when we see at the healthcare center level, the community health workers are not treated as health workers, and they are rather seen as uninvited guests. And their knowledge of the community health conditions are also not invited in larger meetings when they happen. So it's a complex network of hierarchies which come into play, and there is a lack of mutual respect and trust which also emerges from these kind of hierarchies. Yeah. The last slide. I have made some broad observations workload is not well distributed, and over the years it has expanded a lot, and they are not welcome at the local level planning, and they're just recognized more as link persons. Reforms till now have focused more on the expansion of roles, responsibilities, training, and support structures for the community health worker. There is a reluctance to provide support outside the public sector, as there are many training centers to which some of the states have contracted out training, and this, since the contract is not renewed or new ones are not appointed, training is somewhere it gets affected. Then the internal capacities at the district and below needs more strengthening, and some of the states have adopted their own mechanisms for strengthening of the community health care workforce. Yeah, thank you.
Thank you, Bijoya. That was a very detailed and rich account of a complex paper. Right, we've got two discussants, Lewis and Fabiana, and I suggest we take them both and then come back to you for any response to their comments. So, Lewis, would you like to go first?
Okay, thank you. I agree, it's a very rich paper with an awful lot of detail and analysis and description in there. I think what struck me was there's a lot of discussion really that revolves around marginalization, precariousness, and multiple dimensions of that, including around gender. And I was very interested in how that then links to the dominant framing of this, which is around policy capacity. Because it's clear that it's clear that that's extremely important to you and to what you're saying through this paper, but it's not clear to me quite how those two things are sort of systematically brought together. And it seems to me that it's very important to do so, actually. But it seems as though you're sort of missing a kind of political economy dimension to this, almost, in that you appear to be describing a system in which this community health worker type workforce is being created as an adjunct to the state system, but is effectively marginalized in terms of lack of adequate compensation, long working hours, too many tasks, not properly defined roles, and all sorts of things like this. But also, and then when it comes to capacity, then it's unclear to me quite what your judgment is on the capacity. You mentioned at certain points the sort of the increasing status of women performing these roles because they get to interact in the community with people in ways that they wouldn't otherwise and things. But overall, the assessment seems to be around the lack of adequate training and other forms of capacity strengthening that are needed for people to do these roles. And I think it'd be very interesting to sort of bring those two dimensions sort of closer together and to see how what we're seeing, because from what I might be reading this wrongly, but it seems to me that you're talking very much about actually a complicated kind of political economic situation, which is then translating into the lack of opportunities and lack of support, and therefore lack of, and also then lack of capacity in this particular workforce. And I think that's a very interesting story, and it's very important also given the gender dimension to really explore this. I think it would be, but I think the thing, there's a need to sort of to bring these a bit more systematically together and to look at one, there's a set of political economy type of questions, and then there's a set of capacity questions, and then there are things that cut into this very strongly, like gender. So I think there's a lot of very interesting stuff there. And a bit of reorganization, I think, will help to bring those into, to make that come out a little bit more clearly. But I think it's a very interesting set of issues, and thank you.
Thanks, Lewis. Thank you, Fabiana.
Hi, Bijoya. I think we have a very good draft paper with lots of information, descriptions, and analysis about the ASHA. But for now, I think we could be more focused on designing properly the framework. Yeah, you could think of drawing a framework that you be applying in the paper, and taking the concepts that you are presenting there. The two main concepts of your framework could be to start with the organizational and the individual capacity. So you want to explore the relations between those two concepts in the framework, the individual and organizational capacities. And to each extent, they might impact or relate to the health system in various dimensions of the health system that you already have in the paper. Yeah, including the leadership, the workforce, access and coverage, the analytical capacity also of the system. Yeah, and then it will be very rich, your paper. And to better structure all the information you have, you could maybe think of systematizing it. What I mean by systematizing is you take the information from the papers you have, and then you put them into different, let's say, spaces in an Excel matrix related to your framework concepts. And then you'll be systematizing. You'll be able to present a box with systematic information about organizational capacity, individual capacity, and all the elements of health system that appears in the text. You could also maybe classify the articles that you have found on ASHA and select and do a little bit more of research and say that they are showcase good examples, yeah, of what is happening related to ASHA in different municipalities or states. So you'll be working with showcases, case from India, from different paper. So it's a complex way of doing a literature review or mapping. No, it's not a systematic way. And if you draw this framework and then you see lots of ideas coming in, and by doing that, you would probably have to work better on the questions. Yeah, your main question would be in the paper to explore the relationships between these and that dimensions. Yeah, and you have chosen certain dimensions from the policy capacity framework. And then you structure the whole paper. I know that's a draft paper yet, yeah? Your objectives and all the sections you want in the paper are to achieve your objective. And you can leave the descriptive bits to initiate the paper and present ASHA. And then if you decide to go for the systematical way of linking concepts and data information, you can have some analytical sections in the paper. Now, one exploring the relationships between organizational capacity and individual, and another exploring the relationships between those two and health system strengthening elements.
Okay.
So what I have is very good to keep on going.
Yeah, it may be that we need to deal with some of these issues outside this call in terms of comments, but maybe that's for you and Bijoya to speak about. But at the moment, we've got two sets of comments from two discussants, a lot of overlap between the comments. So Bijoya, do you want to respond quickly now and maybe pick up some of these issues later?
Thank you for the comments. Yes, I would be political economy framework is within my mind, and I have a lot to work on, and gender component I've just mentioned briefly, but I have not touched upon. And when I was trying to place policy capacity within the community health work framework, um, as I mentioned, I started just with the worker, and then I realized that there's a lot of has happened and emerged in the last 15 years, and it has to go a little beyond the worker and understand the health work program itself. So yes, but still my focus is I would like to bring in the workers' perspective, and there is as I realize and read more, and I realize there is an important to build the connection between the individual uh, and the organization, as India, as even we looked at the previous paper, the countries being so complex in nature, and I realized with the further reading that you go uh, the, the lens for understanding itself in the policy of community health is differentiated by the nature of the states. When I take individual and the community, the organization, these have to be also built on those lines. Yeah, I take the points and I'll stop here. Yeah.
Okay, that's good. That's good. Thank you for that. Would anyone else like to ask any questions or make any comments? Given that we're pressed for time, but are there anything anyone would like to say at this point?
Yeah, may I say something?
Yes.
Because listening at the two papers, one thing that comes to my mind is that you have conditions that allow the use of capacities. And so maybe we should highlight this, because in the previous paper, there was a lot of analytical capacity that is rare and that have been used. Here, the case is very similar to Brazil. We have very community health workers are in the same position. But then thinking in the literature, what we hear, community health workers have knowledge of the local conditions of the communities. And this should mean an advantage. So but what we hear in Brazil and in India is that they need support, they need working conditions, they need training. If they don't have this, their knowledge is not really used, does not goes into the health system. This is, it's interesting for me because you have an individual capacity there. The health workers have this capacity and it's not being really mobilized into the health system. So I think we could discuss a bit more this, the conditions that allow the use of certain capacities.
Okay, thank you for that, Vera. Any other comments before I close this session? But again, an issue that we might want to pick up in terms of the comparisons between the different country case studies too.
I would, Susan here, I would just, I really appreciate Vera's comment and Bijoya's, and I think this intermediary role of people who are between the community and have that knowledge and also have more exposure than most people to actors within the public health system. And I don't know what mechanisms there are for community involvement in that block planning exercise or other things. But it seems to me that in terms of political capacity, there's a grassroots political capacity that, as Vera says, that what are the conditions that would be needed for that to be exploited. It's fascinating. Yeah.
Okay, thanks for that, Susan. Yeah, Lewis, last comment.
Very quick one, because when we were thinking about the framework and how to use it, one of the things that isn't very clear to me in the way it's presented is actually how one should understand political capacity. And it seems to me that's open to quite a lot of different interpretations. It seems to me also that it's important to bring in a more kind of structured and fundamental understanding of the way that power operates, because that was something we were bumping up against in the way that we were analysing this, but also, that could add, I think, a lot to this kind of idea of capacity, which appears to be somewhat power neutral. It's as though capacity exists rather than it being shot through with power and with unequal relations and all sorts of other stuff.
Okay, right. An interesting point, and something that I think we need to be mindful of in our various submissions. I'm conscious of the time. Stephen's got to go at 3:30. So Fabiana, Stephen, over to you for a final word before we prepare for the next stage in this journey.
Yes. Well, thank you, everyone. We arranged for a meeting with Bijoya so that we can discuss it further and help her. Vera and Louis, if you are interested as well, and even Susan, yeah, if you're interested. The next stages now is the submission. Thought that mid-January would be a good deadline, as we are, most of us very busy in December with reports and everything. So would be mid-January a good date? Maybe 20th of January, yeah? To the deadline, and I'll tell the editors of the journal, yeah? And when I have a very good draft of the introductory paper, I'll share between you all and even the Brazilian paper for comments.
That'd be useful. Good.
So thank you very much again.
Okay, thank you, Fabiana. We'll wait.
Keep safe. Yeah.
You too. Bye, everyone. Thank you.
Bye.
Bye.
Thanks very much, everybody. Bye-bye.
Thank you. Vera.
Fala, Fabiana.